Well, I've got the top of the hour, so we'll go ahead and get started with introduction as we let the rest of the attendees join us. We are proud to welcome you to the July Resuscitation Academy webinar. Summer is underway here in North America, and it is warm outside. So we're very excited to be here today. Really exciting guest that I am just thrilled to hear from and to learn from. Lars Anderson is joining us. Lars is a physician researcher from Denmark and spends his time both in the streets of Denmark as well as at Aarhus University Hospital in a lot of time in the ICU and caring for patients. And Lars is a really accomplished cardiac arrest researcher and has been a key player in a lot of the trials that we talk about at the Resuscitation Academy and that you all follow along on your own. And so I asked Lars to come and do a little bit of an overview for us today on some hot topics and some things that are happening in Denmark that are pretty exciting to me at least, and I think they'll be exciting to the rest of our crowd as well. So Lars, take it away. Thanks for joining us.
Yeah, thank you very much for the introduction. And I get that you said June because that's what I put on my slide.
I saw it on there, and I just,
And I don't know why, like time flies, especially in the summer, but it is July. And thanks so much for having me. Um, I will be talking about some of my own trials, some of the stuff we've been doing in Denmark related to primarily to drugs during cardiac arrest. Sort of drugs outside the ones that are recommended in the guidelines, so epinephrine and amiodarone. I'll basically just walk you through some of the trials we have done, and then we can discuss some of the implications afterwards. And the trials are basically these three. So it's the calcium for out-of-hospital cardiac arrest trial. It's the IBIO trial where we compared intravenous to intraosseous administration of drugs, and I took that into this talk as well because I think it's quite relevant for the whole sort of drug talk as well. Although we didn't compare specific drugs in that trial, just the route of administration. And then I'll briefly talk about an ongoing trial we have in the in-hospital cardiac arrest setting, looking at bicarbonate. Unfortunately, we're not done with that yet, so I can't share any results, but I'll tell a little bit about the rationale for the trial and why we think that's an interesting question. So I'll start with the calcium for the out-of-hospital cardiac arrest trial, the COCA trial. This was published in JAMA a few years ago. So all of this, of course, there's a lot of cardiac arrests, both in the United States and in Denmark, around 5,000 each year in Denmark. Return of spontaneous circulation, around 30%. Survival, depending on the setting, somewhere between 10 and 15%. I'll skip this pretty quickly because this is sort of stuff you probably already know, but I think this figure is quite interesting. It's kind of old data now, but Danish data showing the difference between survival for those with a shockable rhythm, so that's the red line, and as you can see, that's been sort of steadily increasing over time, whereas those with a non-shockable rhythm has maybe increased a little bit, but has remained very, very low. So if you have a non-shockable rhythm, your outcomes are very poor, less than 5% survive. And I think there's been a lot of progress in the shockable group with bystander CPR, defibrillators, AEDs, stuff like that. But we have seen less progress in the non-shockable rhythm. So our focus in a lot of these trials has also been on trying to improve outcomes for this group of patients. So why were we interested in calcium? Well, calcium is something that has been interesting to the cardiac arrest community for a very, very long time. This is an article from 91, and there's also some stuff even before that. And it's something that's been used a lot. And why is that? Well, everyone who works in an ICU know that calcium is a pretty strong inotropic agent and also has some vasopressor effect. Um, Most of us have probably seen it. If you give a bolus of calcium, the blood pressure will go up. It might only be temporarily, but something definitely happens with calcium in that setting. There's also some other potential protective effects of calcium. It has probably a protective effect in hyperkalemia. At least that was the theory before we did the trial. And overall, It's just something that has been of interest to the cardiac arrest community and some sort of that had not really been answered. There has been some trials. These are fairly old, as you can see, they're from 85. They're small. We did sort of just a quick meta-analysis here before we did our own trial. So these were patients, two different studies or similar studies, but two different papers, one looking at PEA and the other asystole. And this sort of seemed to be some signal that calcium was maybe beneficial. If you look at the meta-analysis, if it's sort of to the right, it means it's beneficial. And as you can see, not really statistically significant. And this was only for return of spontaneous circulation, but definitely a signal that there was something here. So all of this made us sort of curious about the question, and even more, calcium is just used a lot. It's very commonly used. We don't have a lot of good data from the out-of-hospital cardiac arrest setting, but the in-hospital cardiac arrest setting, it's probably used in around 1/3 of all patients. So we thought even if it didn't work, it was quite important to figure out if it did, since it's used this much. So we designed our trial, which was investigator initiated. It was randomized, it was placebo controlled, and it was double blind. So basically, no one knew until the end of the trial whether they received calcium or placebo. The trial was conducted in a part of Denmark. Denmark is divided up in these 5 regions, and this was done in one of them. Covers around a little over 1 million people. As you can see here, quite a lot of ambulances and also some physician-manned ambulances, which is maybe a little different than some other settings. We have, at this time, 10 of those in this region. So quite a good coverage. It's a very small geographical region compared to many other places, especially in North America. The inclusion criteria are quite simple. Patients needed to have an out-of-hospital cardiac arrest. They needed to be adults. And then we thought, okay, we need to get started on ALS before we introduce a new intervention. So we thought, okay, let's at least make sure that the patients have received 1 dose of adrenaline. Also, not to interfere sort of with the guideline recommended treatment. So that's when we thought, now we can randomize to our intervention. A few exclusion criteria, traumatic cardiac arrest, suspected pregnancy, if they had received adrenaline by some other unit before the unit that could randomize, and some things like that. And then, of course, if there was a clinical indication for calcium, and that is in most cases some suspected hyperkalemia. It could also be other things such as a calcium channel blocker overdose, although both those are extremely rare, also in this trial. The setup was like this. Someone had a out-of-hospital cardiac arrest. They had either a shockable or non-shockable rhythm, and we started the usual treatment. And once they had received adrenaline, as I mentioned, they could then receive the intervention. And that consisted of 5 millimoles of calcium chloride or placebo, and they were identical, so no one could see which was which. And then if they sort of continued being in cardiac arrest and received another dose of adrenaline, then we allowed for 1 additional dose of calcium or placebo. So they could get up to 2 doses of calcium chloride. And the dose was 5 millimoles for each. And you can see here what that corresponds to in milligrams. And the placebo was just simple saline. You can also see some of our outcomes here. They're also specified here. So the primary outcome was return of spontaneous circulation. The trial was not powered for these secondary outcomes, which were survival and a favorable neurological outcome at 30 days. We did also collect quite a lot of information long term. So we looked at quality of life, adverse events, and we also looked at survival and a favorable neurological outcome and quality of life all the way up to 1 year after the cardiac arrest. So unfortunately, we had to stop the trial early, and I'll get back to the reason why we had to do that, but it ran from 2020 to 2021. As you can see here, we screened little over 1,200 patients, and over here we have the different inclusion and exclusion criteria. As you can see, most patients were not included because they did never receive epinephrine or adrenaline. And that's two different groups of patients. One is those that have a shockable rhythm and then get a shock and then get out of their cardiac arrest. And the other is a group where as soon as the physician-manned ambulance arrived, they realized that, okay, this was probably not a patient that should have been resuscitated in the first place. Could be someone with old age or severe comorbidity and something like that. So it was early termination of resuscitation. And that's a little bit different in a physician manned system because those decisions can be made out on the scene, whereas in some other systems that would require going into a hospital. There was, of course, also some exclusion criteria. You see them here, mostly traumatic cardiac arrest, and only one patient that was excluded because the clinician thought there was a clinical indication for calcium. And I think that's an important point. And in other work, we also see that hyperkalemic cardiac arrest is extremely rare, extremely, maybe less than 1%. Although it's often suspected, it's actually quite rare. And then in trials like this that sort of happen in an emergency situation out on the streets, there will be a lot of exclusions for a bunch of other logistical reasons. So something like the patient got return of spontaneous circulation before we can even give them the drug, or we terminated resuscitation, or we forgot, like it was a hectic situation. We were focused on the airway, something like that. But although this looks like a lot of patients, I'm actually quite happy with these numbers. I had feared that it would be much, much higher. So this, I think, is pretty good. We did include, I think, 70% or something of those who should have been included, and I'm quite happy with that. So we ended up randomizing just under 400 patients. Our goal was around 500, and then we actually had to stop it early. So 200 in each group, roughly, that were analyzed. The patients were very similar to out-of-hospital cardiac arrest patients that you see most over the world. It's actually surprisingly similar when you compare different countries. Most are male, two-thirds approximately, and the average age is sort of late 60s or early 70s in most of these trials. Most of the cardiac arrests occur in patients' home. Most have a non-shockable rhythm. Time to epinephrine was 17 minutes, which is actually pretty fast if you compare to something like the Paramedic 2 trial. And I'll come a little bit back to these times later. That was 21 minutes, so a bit faster. And I haven't seen a lot of systems that can deliver it much faster than this. So the trial drug was given just 1 minute after the epinephrine was given. We use both intravenous and intraosseous routes of administration in our region at this time, and about 60% were giving IO. And luckily, every patient consented to participate, and we had no loss to follow. Over here, you can see some of the characteristics between the groups, and again, similar between the two groups, and also similar to other trials that have been done in this setting. This is just to show that we actually delivered an intervention, which is important when you do a clinical trial, and what you always fear as a researcher, like someone mixed up the trial drugs or didn't actually give the right intervention. But as you can see here, there was a difference between the two groups in calcium levels. These are ionized calcium levels in those who had an arterial gas and those who survived to hospital admission. So a very select patient group, but still a clear separation at the beginning there, and after 6, 10 hours, it sort of fades out, which is what we would suspect from these 1 or 2 doses of calcium. So I was glad to see this. We actually delivered something, and if you compare the statistically highly significant difference there in the beginning. So this is the reason we had to stop the trial. Unfortunately, it actually looked like calcium was harmful. This is return of spontaneous circulation, which was the primary outcome. 19% had return of spontaneous circulation in the calcium group compared to 27% in the placebo group. So a decrease of almost 8%. And that gives a risk ratio of 0.72. And as you can see here from the confidence intervals, they do cross 1 or 0 for the risk ratio and the risk difference, and the p-value is not statistically significant. When the Data Safety Monitoring Board looked at the data and suggested that we stop the trial, the results were actually significant, but then before we stopped it, there was a few more patients enrolled, and this is what we ended up with. So of course, a slightly inconclusive result if we are strict about it, but still highly suggestive of harm, and I'll get back to that later. If we had only seen that for return of spontaneous circulation, perhaps we would have been able to continue the trial, but there was also a strong signal for both survival and favorable neurological outcome at 30 days, with lower survival and worse neurological outcome in the calcium group. For survival, for example, it was 5% versus 9%, which is almost half, so quite a large effect. 4% worse survival. Again, relatively wide confidence intervals here, and again, non-significant results. And these findings sort of continued out to 90 days, which we have here, very similar to 30 days, but actually all the way out to 1 year. And as you can see, for the 1 year outcome, we have 5% and 9% and 4% and 9% for neurological outcome. So if we believe this effect to be true, it's a very large effect. It's like quite a big difference in outcomes for a simple intervention. So of course that was not what we had expected or hoped for, but definitely I thought a good reason to stop the trial, and the Data Safety Monitoring Committee also suggested that. We did, of course, look at a bunch of different subgroup analysis, and I won't go into any detail, but just on the left side, you have the risk ratio. On the right side, you have the risk difference and all the different subgroups listed there all the way to the left, rhythm, time to drug, route of administration, stuff like that. The main point is we really didn't find any suggestion of effect, treatment heterogeneity, no suggestions that the drug worked in some patients and didn't work in others. We did explore this issue of IVIO a bit more and did a sort of small post hoc analysis, just looking at the calcium levels. And it looked like the calcium levels were similar for IV and IO. So the drug was also absorbed in the central circulation for those who got it IO. To better understand the results, or maybe to better explain the results to ourselves and to others, we also did a number of Bayesian analysis. So what the Bayesian approach is basically that you have some prior belief about does the drug work or does it not work, and then you have your data, and with those combined, you get some posterior probability, and that's what we have shown here. So the graphs are for return of spontaneous circulation, 30-day survival, and then 30-day survival with a favorable neurological outcome. And the graph basically shows what's the most likely risk ratio. That's the top of the curve. And then like it gets more and more unlikely the further out you get. And you can also then calculate some different probabilities, and that's quite different from the frequentist approach. This is a direct probability. So you could say something like, what is the probability that calcium is beneficial for return of spontaneous circulation? So that corresponds to this number down here in the left corner. Let me see if I can have my mouse here. No. Showing that the probability that the risk ratio is above 1, so calcium is beneficial, was 4%. And if we say like if it has to have some effect, not just be beneficial, but some meaningful effect, so more than 1.2, so a 20% increase in return of spontaneous circulation. And using this data, that was essentially 0%. And you can see the numbers as well for survival and survival with favorable neurological outcome. And I think the take-home point here is there's a very, very low probability that calcium is beneficial. And I think that's the take-home point from this. So if we have to conclude some stuff, there was no statistically significant difference in return of spontaneous circulation, 30-day survival, or neurological outcome. But the Bayesian analysis showed, combined of course with the other stuff, that there's a very low probability of any beneficial effect. So I think it might be too early to say that it's definitely harmful, but I think it's fair to say it's very unlikely that it's beneficial, or at least it's beneficial with some effect that's clinically meaningful. And then all point estimates, everything we looked at, like quality of life, neurological outcome, survival, return of spontaneous circulation, everything suggested that calcium might be harmful. So why might this be? Well, I don't know. I do clinical trials. I don't do biochemistry or pathophysiology, which I figured out is extremely hard. But there's, of course, a lot of explanations or potential theories. It's been this idea of calcium overload, which can lead to cardiac sort of hypercontraction, that you almost sort of get a heart that can't beat. It's also called the stone heart theory. And then there's a lot of other consequences of calcium overload I'll get back to in a second. You might still ask, what about calcium for some of these special etiologies like hyperkalemia? Um, I didn't bring it here, but we actually did an animal study after this because we were curious about this as well. So we randomized pigs who had hyperkalemic cardiac arrest because we will never be able to do a clinical trial in hyperkalemia. It's not going to happen, at least not in my lifetime, because there's so few of them. So this is one of the few cases I think where observational data or animal study actually might sort of tell us something. So we did a pig model and we could not find that calcium was beneficial in that case either. It did look like bicarbonate was actually beneficial for the pigs, so that's something we're exploring a little bit more. The problem is, of course, the calcium is used a lot, and this is what I was referring to early on, especially for in-hospital cardiac arrest. As you can see here, almost a third of all patients. And it might be that you suspect hyperkalemia in a lot of these patients, but I think you need to have a very high suspicion before you would even consider giving calcium. First of all, there's no good evidence that calcium is beneficial for hyperkalemia. It's based on case reports, anecdotes, good theories, things like that. But fair enough. But then just remember that it's an extremely rare cause of cardiac arrest. And if you then think that for all the other cardiac arrest, it might be harmful, I would conclude that you should probably not use calcium. There are a few points about the trial that I think are strengths. It was double blind. It was delivered fairly quickly in the out of hospital cardiac arrest setting. People mostly did what we asked them to, which was nice. To follow the protocol, gave the drugs. We saw the calcium increase. We had a lot of sort of patient relevant outcome and no loss to follow up. Of course, also a bunch of limitations. The trial was stopped early, which means that the confidence intervals are wider. We had fewer patients, fewer outcomes, which makes the results more uncertain. We only tested one dosing regime and timing. Some might argue you should give it later, earlier, higher, lower dose. And then we don't know if this also would apply to the in-hospital cardiac arrest setting. So a conclusion for this trial for me is don't use calcium during cardiac arrest. To me, this is fairly simple. I think um, there's a very strong signal of harm here. I would be concerned that we are harming our patients if we give them calcium. Could there be some very specific indications? Sure. Not long after I finished the trial, I had a patient who came in with a calcium channel blocker overdose, and I was thinking a long time about it, maybe too long, but I finally gave the guy some calcium because there might, of course, be some situation, but I would be careful. And then pathophysiology is complex. This is what I've learned. I thought we had a good idea, but the problem is that something like calcium, this is a map of some of the biochemical pathways in the human body. And calcium works almost on every single enzyme and protein and everything in the human body. It works in the coagulation cascade. It works in muscle contraction. It works for ischemia, reperfusion injury. Calcium is involved in everything. And thinking that we can give one drug and it will just have one effect, like an inotropic effect or a vasopressor effect, is just naive. And I was naive. I don't know what calcium does to ischemia reperfusion injury, what it does to muscle contractility in a cardiac arrest state. And I think we have to be humble about understanding that even in the healthy human body, this is complex, and it's even more complex when someone has a cardiac arrest. Um, so it's fine to have some good hypotheses, and I'm glad we tested it, but we need to test these things in clinical trials because we can't theorists have a theory and then think that's just how it applies. So we have to test it somehow. Okay, so that was all I had about calcium stuff. And I'll just a little briefer go into this one, which was the intravenous or osseous vascular access for out-of-hospital cardiac arrest, which was published in the New England Journal of Medicine last year. Um, so this trial was done in the entire country of Denmark. Before we were just in that central region. Now we're in all of them. So there's about 6 million people in the 5,000 cardiac arrests as we talked about. Um, we have the ambulances and the physician-manned ambulances, and then also some helicopters that was also part of this trial. So good coverage again for a fairly small country, which is probably also why we can get some of those good times. As I mentioned, the standard of care, at least in our previous trial, was sort of almost 50-50. 60% got an IO and 40% got an IV. So this is important because it means that the clinicians were used to doing both. So it was not a new skill that anyone had to learn, and everyone knew how to do both procedures. So again, investigator initiated a trial, two groups. We looked at to see whether one group was better than the other. We made sure that the clinician didn't know the intervention until the last moment. So right when they were going to put in one of the two, they opened an envelope and said, okay, it's IV or it's IO, just to make sure that there was no bias. And then we randomized 1 to 1. So to IV and IO. And then within the IO group, we also randomized to humeral or tibial because we were very uncertain when we designed the trial which one we should pick. There's sort of arguments for both. Tibial is probably easier. Some argued that humeral was better because it's closer to the heart. So instead of guessing, we decided why don't we just test it? I won't go into that too much today for a lack of time, and I'll focus on the IV versus IO. You had two attempts with each, and everyone was blinded after the cardiac arrest. So people, when they came into the hospital, no one was sort of told what they were. Of course, they could sometimes see it. The inclusion criteria were age above 18, like before, out of hospital cardiac arrest, and then an indication, of course, for one of these. The exclusion criteria were, again, traumatic cardiac arrest, and if they already had some vascular access, there's no point in randomizing them. Primary outcome, again, return of spontaneous circulation. As you can see, some things are the same here. We had a setup and it worked, and we just did it again. And we looked at a bunch of procedural outcomes, adverse events, quality of life. And then we also looked out to 90 days, 6 months, and 1 year. We're just finalizing the long-term outcomes now. They'll be out soon. This trial ran after the other one from 2022 to 2024. Um, this time, most patients were excluded because they didn't have an indication for vascular access. This was again someone who got early return of spontaneous circulation or where resuscitation was terminated very early. Then some patients had a functioning vascular access, and these are not patients who walk around at home with a IV access. It's more that some other unit was there before, the randomizing unit, sort of the unit that could randomize arrived. So that's why they were not included. But we randomized 1,500 this time around. A few were excluded, and then we ended up with approximately 750 in each group. Most of those received an attempt at vascular access, and this is the difference between a drug trial. Here, there's sort of a gap between the randomization and when you actually get the intervention. So, of course, some patients will have return of spontaneous circulation, or some might terminate. So, more attempts in the intravenous than the IO. So again, very similar characteristics as to what we saw in the other trial. Of course, it's the same patient group. Mostly men at home, non-shockable, a lot of bystander CPR as we see in Denmark. Response time fairly quick. And here we have the results. Oh, sorry, this is the humeral tibial. Well, it's almost the same. I think I took the wrong slide here, but the gist is the same, that there was no difference between the two groups in either return of spontaneous circulation, 30-day outcomes, or 90-day outcomes. Here we see some of the first attempt success rates, and it was much quicker getting or easier getting the IO in on the first attempt than it was getting the IV, as you can see here, 80 versus 60% and 90 versus 80 for a second attempt. But what was a little surprising to us was that the time was actually the same. So the time to successful vascular access was the same in the two groups, approximately 6 minutes after arrival on scene and 14 minutes after the cardiac arrest. And the time to adrenaline was also the same. This was a little surprising, but actually something we also saw in the very similar trial from the United Kingdom, illustrating that even though it's a little easier maybe to get the IO in on first attempt, maybe it takes a little longer to prep, or there's some other issue. Displacement rates were quite low in both groups. We did also do a meta-analysis. There was a large British trial published at the same time. And if we combine the results there, we really don't see much difference. The British trial had slightly better return of spontaneous circulation with the IV group compared to the IO group, but no difference in survival or neurological outcome. So there was really no difference in outcomes, whether you used an intraosseous vascular access or intravenous vascular access. We also found no clear difference between tibial or humeral. And I think this indicates that the effects of the drugs probably do not depend a lot on whether you give them through an IV and an IO. And although there's still some long-term outcomes and some other stuff pending, I think the results are quite clear here with two large trials that there is no difference. And that means that you can basically do whatever you think is appropriate in the given situation, what you're trained to, what you have the resources to do, and what you think might be appropriate for the patient that you have in front of you. So that was the out-of-hospital cardiac arrest trial. Then I'll just briefly talk about our ongoing in-hospital cardiac arrest trial looking at bicarbonate. So just a few words about some of the differences and similarities about in-hospital and out-of-hospital cardiac arrest. We did a paper a few years ago where we looked at all the in-hospital and all the out-of-hospital cardiac arrests in Denmark. And it was actually a little surprising to us that they were quite similar. There's a lot of ideas that the groups are very different, but it actually turned out that in most characteristics, the groups are very similar. So they have roughly the same age, same sort of sex distribution. They are a little sicker, the ones who have in-hospital cardiac arrest. As you can see here, they have more hospital contacts. And they have slightly more comorbidities, but it's not sort of a crazy difference. It's like, look at ischemic heart disease, 24% versus 17%. So a fairly similar patient group. They were also similar in terms of how many had a shockable rhythm, around 20%. But this is where we get into the things that are quite different. So as you can imagine, of course, most in-hospital cardiac arrests are witnessed by health professionals, whereas that's quite rare in the out-of-hospital cardiac arrest setting. And then the lowest number there is time to the initial rhythm analysis, which was 2 minutes for the in-hospital cardiac arrest setting and 10 minutes for the out-of-hospital cardiac arrest setting. And that illustrates the main difference between these two groups, that it's a matter of timing, that we are just much quicker at the in-hospital cardiac arrest than we are at the out-of-hospital cardiac arrest. And we did some analysis, and that's probably also what explains the outcome difference in these groups, because in-hospital cardiac arrest actually tends to do better, although they have more comorbidities and they have more other things. And that's probably because we're there earlier and can do more stuff right there. And that's I think an important point, and we can also see it in the trials we've done. This is a early in-hospital trial up here on the left. So the two out-of-hospital cardiac arrest trials, it took 15 minutes to give adrenaline, 18 minutes to give the intervention. When we did it in the in-hospital setting with a different intervention, it took 5 minutes to give adrenaline. So I think if you're interested in drugs during cardiac arrest, in-hospital cardiac arrest is actually the ideal setting to test it. Because I think we can all agree that if you wait long enough, no drug will work. Like if you give a drug after 30 or 40 minutes, there will be no effect because the patient is almost always dead. Or they need something else like ECPR or have some reversible cause we have to fix. A drug is unlikely to make a big difference, at least at that time. So I think to show that something works, it might actually be ideal to do it in the in-hospital cardiac arrest setting. So one of the things we have been interested in is in bicarbonate, and why is that? Obviously, severe acidosis is very common in cardiac arrest, both during and immediately after the cardiac arrest. Our previous trial was this VAMICA trial looking at vasopressin and steroids. There we looked at what was the pH right after the cardiac arrest. Again, we only have blood samples and those who survive. And the average was 7.05, so quite low. And if you look at the association between the pH and survival, you find a very clear, the lower the pH, the worse. And obviously that could be confounding. It could be some, because they're just more sick. But we do know from animal studies and from other sort of lab-based stuff that acidosis is bad for cardiac contractility. It does lower the effects of catecholamines, and it might also increase neuronal injury, especially in a setting of ischemia, which is, of course, quite common during cardiac arrest. So we thought there was at least some argument to look at this further. We are not the first who had that idea. Here are some trials, a few older ones, and then a slightly newer one. The older ones are actually fairly big for that time, 500 and 800 patients. I think one of the problems with those trials is probably that the intervention was delivered very late. They didn't report it in their manuscripts, but you can see I think it's a Korean study, the last one, the time to the drug was 31 minutes. And that's because they had to come into the ED and then they were randomized. And all of them were out of hospital cardiac arrest. If we combine them, and it's just a simple meta-analysis down here, we can see there's really no signal of benefit or harm. But I think it's hard to interpret these studies, especially the older ones. They were done at a very different time and a little unclear when the drug was delivered. Bicarbonate is mentioned in the 2021 guidelines, and it said don't use it sort of routinely, but you can again give it during some special circumstances, hyperkalemia, and then some specific toxicities where it's recommended. But again, not recommended for the routine cardiac arrest. And then it's once again very interesting when you then look at how often it's used. And this is data from primarily the United States. So in our own trial, it was used about 9% of the time, like the other trial that had nothing to do with bicarbonate. But in the United States, it's very common. Almost half of all patients get bicarbonate when they have an in-hospital cardiac arrest, especially if you have a non-shockable rhythm. And that's interesting because it's not like it's recommended in the American guidelines either. So this is something that clinicians do outside of the guidelines. And I'm sure there's good reasons for it. Um, but at least the people who write guidelines have some work to do because they're not being followed out there. But we wanted to figure out whether this was actually a good practice. So we designed this trial, the BICA trial, we called it, bicarbonate for in-hospital cardiac arrest. It's again an investigator-initiated multicenter randomized placebo-controlled trial. It's double-blind. We're looking at 22 hospitals in Denmark. It's basically all the hospitals in Denmark, except the very small ones. And we are hoping to include just under 800 patients. And these are all the hospitals in Denmark. And again, the setup is very similar to our other trials, where we randomize patients after they get adrenaline to either bicarbonate, and this is sodium bicarbonate, 50 millimoles, or placebo. And then again, we do it one more time if they are still in cardiac arrest and receive another dose of adrenaline. And of course, we can spend a long time discussing this dose. It was a pragmatic choice. It's sort of the dose that's recommended in the guidelines if you give bicarbonate. But we also thought it was reasonable to repeat it at least once. I think in the ICU, we would often, at least in our place, give 100 millimoles. So that was sort of a natural thing to pick the total dose here. This is, again, a trial that's powered for return of spontaneous circulation. It is extremely hard powering trials for survival, and we haven't succeeded in that yet, but we're hoping to see if we can find a difference in return of spontaneous circulation. The trial is going quite well. The graph is not fully updated, but the numbers are. So we have almost 650 patients included. So we're missing just 130 until we're done. So hopefully we'll be done early next year and we'll then be able to present the results sometime in the summer next year. And I think that should be very interesting. Before I end, I just wanted to tell you briefly about our new out-of-hospital cardiac arrest trial. Nothing to do with drugs, but just so you know what's going on. This is also a trial where we're looking for additional sites. So if someone is interested, please shoot me an email. You can read more about the trial on the website. So most of you have probably heard of the DOSE VF trial, the primarily Canadian trial that was published in the New England Journal of Medicine a few years ago. Cluster randomized trial that looked at different pad positioning for shockable rhythms, looking at anterior lateral, which is the standard approach, anterior posterior, or double sequential defibrillation. So we are basically trying to do the same thing. Instead of doing cluster randomized trial, we will do individual randomized. So patients will be randomized out on the scene, and they'll be randomized to one of these three groups. And the plan is to include roughly 900 patients, and we have included the first 50. So there's a long way to go, but we are looking at finding international partners here as well. So shoot me an email if you're interested, or read more about the full protocol. It's also on the website. Thank you.
Awesome. Thank you so much. That was a really tremendous review of some excellent work. I invited a couple of our distinguished guests from the audience to join us, and I know Tom Ray took me up on my offer. I'm sure he has a list of questions that are burning, and I saw Mo Daya jump in too. So if you guys want to jump in with some questions, that I think we have about 15 minutes or so that we can discuss this fine work.
I will defer to Tom first.
Yeah, well, thanks, Mo. I always appreciate your polite Oregonian nature. So my first comment is I don't believe Lars I've ever met you, but my goodness, what an accomplished and important set of work you've done. It's really terrific just to listen to you cover such ground in such a conversational yet eloquent way. So really, that was fantastic, and you're so humble in the way you present these results, but it's truly remarkable the work that you all have done. So I have two questions. One is sort of a specific question, just nibbling at the edges because the quality of the work is so outstanding. And then another one is a more sort of broad-based question about how you do this work. So the first question is about timing. So you emphasize just how important timing might be for the drug trials, and you did present the median times for when the interventions were performed, and you may have shown this as well, but I might have missed it. But did you look at subgroups for whom the medications were given very early, with the potential that maybe there would be differences based on the timing of the drugs? Yes,
Yeah.
it's for calcium, really. Well, no, actually, it's for the IV trial as
Yeah,
well.
no, that's an excellent question. We did look at it in a very rough way, you can say. So we sort of dichotomized it by the median and then did a subgroup based on that, and couldn't really find a
Okay.
difference. And I think it's such an important question that I'll just follow up a little bit on it, because I think timing is very essential. In an ideal world, we would probably look at it at a more sort of continuous variable and see whether it's an effect very early and not very late. The problem is that we just don't have enough patients to do that. We don't have enough data to look at these sort of more complex things. And even the Paramedic 2 trial, which looked at adrenaline, randomized 6,000 patients. And in their analysis of this time effect, there's actually, if you look at the graph, a very clear, large beneficial effect in the beginning and no effect very late, but it's not significant because
Okay.
it's almost impossible to find a significant subgroup effect in these trials, because you would need thousands, tens of thousands of patients. So it definitely looks like there's a huge sort of effect in the beginning and not late for adrenaline, it's uncertain. And I think we might find some of the same things. I doubt, again, if you give calcium after 40 minutes, it's not harmful, it's not beneficial, it does nothing. But whether you give it very early, I don't know.
And then, Mo, if you allow me, I'll ask one more question. And I don't want you to, Lars, to go into the details here, but it would be very useful, I think, for some of us to understand how Denmark, and perhaps you in particular, you have this sort of continuous pipeline of really high quality randomized resuscitation trials. And we had that for a while with the Resuscitation Outcomes Consortium, but it really has been difficult for investigator-initiated research to have that sort of ongoing. You finish one study and hey, the second one is, or maybe even before you finish, you're moving forward. So how have you been able to organize this in such a productive way?
Yeah, no, that's a good question. I think the most important thing is that we have an organization that is willing and capable of doing research. And I think that requires some leadership and some on the non-research side, like it requires people to say, okay, this is something we want to prioritize, and this is something we want to do. So the leadership has been supportive, and then actually sort of people out in the ambulances have been super supportive of this and said, okay, this is actually fun. Like we're learning new things, we're participating in research. And that sort of combination of having sort of both from the top and from the bottom supported has been very strong. And then I just been lucky to work with a lot of good collaborators where we come up with a good organization so we don't have to sort of reinvent everything every time. So it makes it much more efficient. And then we have pretty good sort of independent research funding in Denmark. Although it's a small country, we have a lot of industry, like farm, like we have Novo Nordisk, for example, and they actually throw a lot of money into independent research that has nothing to do with what they're doing. So we've been lucky of like been able to find money that both from the government and from more independent sort of research foundations. And it's probably the good thing is once you have done one or two successful trials, they see, okay, they know what they're doing, and then they're willing to fund it again. The problem we have in Denmark is that we're just too small. Like we're too small to do the very big trials. So we can't do the 30,000 randomized patients like the Research Outcomes Consortium did back in the day because we're simply not big enough. That is also why we're trying to expand for this defibrillation trial to other sites because we will need 900 patients with a shockable rhythm. We just don't have that many patients in Denmark. So we're looking at partners in Finland and in Belgium and maybe in Ireland as well, and maybe more places if anyone is interested. That was the shortest answer I could give.
Yeah, no, that's terrific. Thank you.
So Lars, thank you very much. And it's a pleasure to listen to how you've done these trials. So let me kind of take a tack and ask you this challenging question about who you're including in these studies. So you have basically included every type of cardiac arrest. And both of the trials so far, the calcium and the IVIO, have shown no difference. Because I think one of the things is that we're trying to treat everything the same way. And this has been true of a number of questions is, should we be a little bit more thoughtful and rather than just give calcium to, for example, a VFRS, which I ordinarily don't do in my practice, but I do it in someone who I suspect hyperkalemia, which is not rare, but I've seen it work in front of my eyes, which is the same thing with bicarbonate occasion in the same context of hyperkalemia. So how do you reconcile this? Because science guides you when you do it across the broad population. But really, many trials today, people talk about the N of one. So how do you rationalize some of your findings? We're trying to understand that.
Yeah, no, that's an excellent question. I think that's a complex and much broader question that applies to many other things than cardiac arrest, intensive care, and everything else. Should we do large pragmatic trials where we can get a large number of patients, or should we do small, very focused trials in specific patient groups where we then have the disadvantage that it's almost impossible to get a large enough sample size to see anything meaningful from a statistical point of view? And I'm not saying one is correct and one is not. I hear your argument that I think there are one size fits all probably is not true. My approach has been that I would rather include 600 patients and then look at some subgroups than only include 200 patients that had a specific characteristics that I thought would be good to give CAS, but I don't know. It could also be it was the other group or someone else or um, so of course you have to do some things like we didn't include traumatic cardiac arrest or something else. We didn't include children, um, but I'm probably leaning more towards doing the larger trials, and large I mean still in the hundreds, not in the thousands, but and then try to look at some of these subgroups. And the calcium is a good example. We did quite extensive subgroup analysis looking at patients with PEA. We looked at we had rhythm analysis of all the patients, so we looked at quite detailed ECG characteristics. Was there anything in the ECG that would suggest hyperkalemia? Broad QRS complexes, the T wave, all these things that are traditionally associated with hyperkalemia, and we found nothing. Of course, we don't have the potassium level out in the ambulance, but I'm not. I think if we somehow knew which patients would benefit, then it would be great targeting those. But if we knew that, there was no point in doing the trial. So it's a little bit perplexing, but it's an excellent question, and I'm not saying our approach is the right one. It's just that's the one we've done.
Yeah, I only ask that because I think sometimes research gets interpreted in the context of, well, it didn't work, so let's throw it out. So you throw out epinephrine, we throw out calcium, right? We essentially begin to say none of these drugs work. Yet I think there are probably a little bit more nuanced questions and answers. And again, if you look historically at some of the cases that wake up in the morgue that were pronounced dead by EMS, several of them actually turn out to be hyperkalemic cardiac arrest that wake up because for some reason their heart begins to beat again. It's been interesting phenomena. My other question, I guess, to you, getting back, it really, I find I'm glad you're doing the bicarbonate in hospital cardiac arrest. I think it's another question that is challenging. There is some data coming out today, people looking at blood tests in cardiac arrest. I'm not sure how to interpret it given the low flow state as to what it really means. But there are cases where they do find that both lactate and potassium, not surprisingly, go up with time. And so given that phenomena, maybe there's something. But the challenge, I think, within hospital is it's not the same population, particularly since many of the arrests occur in the ICU or in a critical care unit where witnesses are much more present. We do see some floor arrests, but they're typically more sepsis, pulmonary embolism, those sort of respiratory arrests than they are true sort of primary cardiac in nature. So although the population is changing, we have much more chronic diseases that we send home today that ultimately arrest for the same reason. So it'll be interesting to see how we learn from that trial. In your IV versus IO, you mentioned calcium levels when you did the calcium study. In your IVIO, did you look at any other levels? Because I think you probably recall that Peter Kutenchuk and us, when we did the ALPS trial, we actually found that the IV route was much more, it was a post hoc analysis, but it appeared that the IV was better for lidocaine and amiodarone because they're very fat soluble drugs. And there's a lot of fat in the bone marrow that may be absorbing some of the drugs. So did you, by any chance, look at any of that, or do you have anything like that you could look at?
Yeah, so no, we didn't do any sort of specific blood work or anything after. So these calcium levels was just what was measured in clinical practice, so we can sort of pull that data. The ALS trial was one of the reasons we wanted to do the IVIO trial because we saw that subgroup analysis and thought that was interesting. We were not able to find the same when we look at those with a shockable rhythm. We also see no difference. We don't use much lidocaine in Denmark, but we do use amiodarone. So I'm not, again, the numbers are small in that group, so I wouldn't be too confident concluding anything. But we were not able to see the same thing as you did. Just one comment about the in-hospital cardiac arrest. I think the demographic of in-hospital cardiac arrest is quite different in Denmark, Europe, and the United States. Only about 10% of our in-hospital cardiac arrest occurs in the ICU, where that's more than 50%, I think, in the United States. So there's something there that is very different, and maybe that's a concern when we have to sort of generalize these results. And we have just done a big study where we looked at the cause of cardiac arrest. We actually did post-mortem MRIs and CTs and stuff. The articles should come out soon. And it's about a third that have a cardiac cause, a third that have a respiratory, and a third that has something else. So it's a bit of a mix, but I think it's very different depending on where you work, what kind of institution you're at, who's in the ICU and who's not.
Thanks so much. I think I will let the team take it back. It looks like there's a lot of questions in your Q&A.
Thanks, Mo. Thanks, Tom. A couple questions in the chat. One is, you mentioned sort of 1% of cardiac arrests are hyperkalemic, and I know at least in some communities in the US, right, there's a pretty high preponderance of patients that are on dialysis and have arrests. And so would you sort of feel that there's equipoise in this subpopulation where they can be concentrated in some way to try to study that sort of population? Maybe it's people who arrest at dialysis, or there's some way to sort of find these folks in a higher concentration and study.
Yeah, no, I think that's an excellent question. The 1% is not it's sort of there's been a few reviews and sort of the causes of cardiac arrest, and it's always sort of based on, chart review and guesses about, and it is very low when sort of that sort of label gets on the cardiac arrest. So that's what I'm basing the 1% on. With everything, it depends on where you work. Obviously, if you work in a dialysis unit, it's going to be much higher. Similarly, if you work in a cardiac ICU, you're going to have more shock of a rhythm, or if you work in a surgical department, you might have more non-shockable rhythms. I think the question of calcium is still interesting. I think it'll be very hard to do a clinical trial of hyperkalemic cardiac arrest. I think we can do other things. So we've done our PIC model, and now we're looking more into what does calcium do in those patients who have severe hyperkalemia but no cardiac arrest. So we're again starting with a PIC model there to see, does it even do what we think it does? Like, how does it change the ECG? There was a publication in Critical Care Medicine just, I think, a few years ago showing that the whole idea of sort of membrane stabilization is actually wrong. It's different targets. So the thing is just super complex. And we are exploring it more. And I think it'll be interesting to also look at dialysis patients who have like chronic hyperkalemia. Does calcium do anything there? But it will be at a lower level of evidence, but because I don't think we're able to do that trial. I'm quite skeptical whether calcium does anything
Yeah.
for hyperkalemia, but you can't quote me on that, or you can, but don't change your practice based on it. We're still working on it.
Yeah, I think that's a great way to sum it up. One more question. I think it's a really good one. And Josh Kimbrell brought it up. Some trials recently have started using sort of ordinal outcomes, alive and ventilator-free days being one of these, to study cardiac arrest interventions. And maybe they have slightly different power and need slightly different, cohort size to study. Kind of curious your thoughts on those types of endpoints versus our traditional ROSC or survival endpoints that you guys have pursued historically.
Yeah. Whew, you're opening up a can of worms.
Sorry,
That-
with 3 minutes left too.
Yeah, no, that is a long discussion. I think it's very interesting. I'm not sold on the idea yet for multiple reasons. First, I think a lot of them are hard to interpret clinically, especially some of these alive and out of the hospital. They also turn out to be quite complex to analyze from a statistical point of view, and the assumptions there are quite hard to follow, and the assumptions are sometimes hard to meet. My main concern is that we will get results that no one understands,
Yeah.
and then no one will follow it. I think in some interventions, maybe especially post-cardiac arrest interventions, so interventions in the ICU, that there might be some interesting ordinal outcomes. I think for during cardiac arrest, I haven't found anything else that returns spontaneous circulation, and I have been looking for a lot of stuff, biomarkers, ordinal outcomes, continuous outcomes, but I think it's really hard, and I haven't seen a lot of good examples of it working. And I know there's probably people out there who have used them, and I think in some cases it's fine. Yeah, I'm a little worried, but I think we do need to come up with something, because we cannot randomize 10,000 patients over and over and over again, especially if we only believe the intervention works on 500 of them, right? So
Yeah.
so we do have to come up with something, and I think we have to keep working on it.
Awesome. Well, thank you so much for joining us. Mo Dia, Tom Ray, thanks for jumping on the panel there last second and chiming in with excellent questions. And Lars, I mean, open invitation anytime you're ready to come back and talk about dual sequential defibrillation or bicarbonate or anything else that is on your mind. Just let us know, and we'll have an audience for you, because this was fantastic.
Sounds good.
I really appreciate you taking the time, especially 10 o'clock at night in Denmark. So we really appreciate that. Totally understand how this works, but just a tremendous session and really, really grateful. So thank you so much. We'll go ahead and wrap up there. We're back the third Thursday in August, and we'll have another exciting session for you then.